if you work for an organization, just so that we can know who we have today. We're going to get started in probably another 2 minutes or so. So we're going to wait on a few more folks to come in. Hi, Ron. Good morning. Good to see you. Hello, Carmen, Alex.
Hey, morning, Gert.
Kenya.
Hi, Lindsay.
Good morning, Ron. How are you? Great to see some familiar faces, some new faces in the room. Get started in a second. Guatemala and Venezuela, great. Alex, thanks for joining.
Thank you.
Hello, everyone. Thank you for joining. Please, if you'd like, just go ahead and put a greeting in the chat. Let us know who you are, where you're coming from. Hello, everybody. Thank you, Richard. All right, we've come to the top of the hour. Give 1 more minute because we know we have some more people who will be coming in. We have a really great agenda for you today. So hi, Nancy. Hello, Samuel. So go ahead if you'd like and put your name, where you're coming from, your organization in the chat, just so we know who you are. And then we'll get started in about another 60 seconds or so. All right, Lindsay, you would do me the honors of the slide. Okay, so because we have so much that we'd like to cover, I'm going to go ahead and get started. Hopefully we'll have more of our guests come in. So good morning, good afternoon, and good evening to everyone. Welcome to the Washington Healthcare Facilities Community of Practice Initiative. We are really glad to have you join us for a very special session today that actually brings us to the end of our 2nd year of the Washington Healthcare Facility Initiative. And entering into our 3rd year, we have some really exciting changes that we're going to discuss later on in the meeting. But for now, we have a jam-packed agenda that includes several components. And so we really hope that you can hang in there with us for the 90 minutes. In the first segment, we're going to discuss some ways that the WASH and health community can respond to the newest global recommendations for Washington healthcare facilities that was associated with the global report released back in June of 2023. Then we're going to do a brief overview of this community of practices, resources, and all of the tools we've been providing over these past 2 years that will hopefully continue to support you as you continue your work in advocacy in Washington healthcare facilities. Then we're going to turn to behavior change. Yes, a topic that is often talked about in Washington healthcare facilities, but it's not always clear as to how do we go about setting up programming. So for that, we're pleased to welcome a special guest, Christy Craig from the Centers for Disease Control and Prevention here in Atlanta, who will talk to us about her experiences as a WASH behavioral scientist and the nuances of how we develop and launch behavior change initiatives for health workers aimed at improving WASH in healthcare facilities. So we have a lot to get to, so I'm going to move through our introductory slides pretty quickly so that we can get to these different presentations. But before we start, as always, I want to acknowledge and thank our amazing Community of Practice Learning team, who has worked so hard, not only putting together this session, but all of the sessions over the past 2 years. So I will introduce myself for those who are not familiar with me. My name is Joanne McGriff. I'm an assistant professor in the Department of Global Health within the Rollins School of Public Health here at Emory University. And I'm also core faculty within the Center for Global Safe WASH at Emory. We also have Lindsay Denny from UNICEF New York, who is also a long time affiliate with the Rollins School of Public Health, as well as a key mastermind for this community of practice. So welcome to Lindsay. We have Haley Elling from World Vision, who some of you may not realize, but Haley's the one that puts together that wonderful newsletter that you get periodically every month. And I tell you, she's in the foreground and the background of logistics and helping us do so many things here with the community of practice. And so welcome to Haley. And then we have several members of our community of practice steering committee somewhere in the virtual audience. These are the great partners who provide guidance for us into the development and implementation of these sessions. So we welcome our steering committee members. And then as you see here on this screen, our other team members, those who really help our community of practice flourish and amplify the messaging and all the great information, are our interpreters. They will assist us today with Spanish and French speaking participants. So if you can, please go ahead now, look at the bottom of your toolbar and choose your language of choice right now, just so that you'll be able to hear and participate comfortably for the next 90 minutes or so. So next slide. I want to take a few minutes to welcome new participants and remind some of our older participants of the community of practice and tell you a little bit about what we do and who we are. So we are an action-oriented learning platform that brings together the WASH and health community to focus on policy, evidence, and practice in WASH and healthcare facilities. Our goal is to connect the expertise and experience of our partners and colleagues to the members of the WASH and health community who have expressed interest in taking action in WASH and healthcare facilities. We've created this platform as well as our newsletter that I talked to you about, our webpage to share resources with the WASH and health community. And our goal for each session that we have that's live is that participants walk away with tangible information that will allow you to make almost immediate steps to advance the improvement of WASH and healthcare facilities. Next slide. I also want to remind everyone of the guiding principles of the COP, or the community of practice, so that you know what we are, what we believe, where we're coming from in these webinars, or when you see some of our materials. So we believe that WASH is a fundamental prerequisite for quality care within a healthcare facility, that there can be no effective infection prevention and control without adequate WASH. We believe that dealing with WASH in healthcare facilities is a solvable issue, but it will require multiple systems, sectors, stakeholders in order for us to work together in order to see sustainable improvements. And then, of course, the community of practice is open to all who seek to learn and share about WASH in healthcare facilities. And so we welcome all of you with respect to the diversity of your perspectives and what region you're working in. So whether you're a seasoned expert or someone for whom this topic is new, we welcome and appreciate your participation. Next slide. Each time we come together, we want to make sure you have the latest information and resources for WASH and healthcare facilities. So for this session, we feature the new WASH Fit guidelines developed by the Department of Health of the Philippines. So they basically took the WASH Fit, as we all know it, and have been talking about it for quite a bit here on this platform, and they streamlined it and customized it to include examples and guidance specific to the Philippines. Country partners who might be looking to adapt the WASH Fit protocols into specific national or regional contexts. So take a look at this new set of guidelines and see if there are ways that perhaps you can also adapt the WASH Fit to work in your context. Next slide. So we also like to highlight stories from the community that showcase successes, wins, progress as it relates to WASH in healthcare facilities, whether great or small. However, success or progress is defined. And so for today, we decided to take a step back and look at the impact of advocacy and awareness raising efforts over the past 8 years, and with special emphasis on linkages of advocacy to financial investments in WASH and healthcare facilities. So we have a nice list here of important successes to acknowledge. So just to name a few, the African Development Bank has prioritized health infrastructure, namely WASH, waste, and energy, in their new health strategy, which is a major win in terms of moving the focus and potentially garnering resources. The Republic of Korea has funded WASH and healthcare facility in 22 countries through UNICEF as part of health system resiliency post-COVID. Additionally, a growing list of government donors from the UK, Canada, US, Australia, Sweden have supported Washington Healthcare Facility programming. Skipping down, the World Bank is funding large-scale healthcare, Washington Healthcare Facility programming in East Africa. Most importantly, national governments are allocating domestic funds for Washington Healthcare Facilities, such as what we're seeing going on in Ghana. So these are really important successes that we want to acknowledge in terms of just what happens when agencies, organizations, donor countries are becoming much more aware and committed to Washington Healthcare Facilities, and then we're seeing it convert itself into real investment. So this is certainly something that we want to acknowledge and celebrate. So next slide. So just a reminder of our agenda, I'm going to turn things over to our learning team members. So Lindsay Denny will provide the recap of the new global report as well as its recommendations. Then Haley Elling will come on and follow with the summary of this community of practices resources. And then I'll come back after after all that with part 2, where we'll focus on behavior change in healthcare facilities with our special guest, Christy Craig. And then lastly, we'll talk about plans for year 3 of the community of practice, our new Washington Healthcare Facilities course that we want to tell you about. And then we'll hear from colleagues from the University of North Carolina Water Institute and sort of their role in this next phase of the community of practice. So lots to do. I'm going to go ahead and hand it over to Lindsay to get us started with the global report and recommendations. Lindsay?
Great. Thank you so much, Joanne. So as many of you may be aware, there was a global progress report on Washington Healthcare Facilities. Actually, it's Wash, Waste, and Energy in Healthcare Facilities that was published back in June. You may have read the report or participated in the webinar that was held in early September on this topic. But essentially, this report goes through a comprehensive review of progress to date in 73 countries and gives insights into successful strategies, challenges, and the way forward. The report includes data from the JMP. It includes progress on the 8 practical steps, a discussion on financing, and then recommendations. And really what I want to focus on today is this last part, the recommendations, and how we as community members can help respond to those. But first, for those who aren't familiar, just a really quick recap. The report goes through the 2021 data from the JMP. So you may have seen the JMP report that came out last year. And then this is being recapped in the progress report. So this is not new data, it's just new visualizations and summaries as it applies to all of these pieces we're talking about, progress in countries, recommendations, etc. So you can see they've gone through, and they also have added electricity to this. Nearly 1 billion people are served by healthcare facilities with unreliable or no electricity supply. So thinking about this full package and having a bit of a extended conversation here about what is needed in a healthcare facility: water, sanitation, waste, environmental cleaning, hand hygiene, energy. There's also a chapter on financing. And if you're familiar with the Lancet study on what it takes to finance the 46 least developed countries to basic wash services, this is a summary of that Lancet article. But again, with a bit more analysis, a little bit less scientific into the methodology, and more of a focus on what it's going to take for us to address those funding gaps. And again, this figure might look familiar. They had published this in the Lancet report, demonstrating that the biggest cost here is going to be for healthcare waste and sanitation, both for rural and urban, as well as hospital and non-hospital settings. So if you haven't had a chance, I would recommend taking a look at this report. It will also go into a snapshot of the progress on the 8 practical steps. So WHO and UNICEF reached out to country partners to get an update. These updates were then validated from the Ministry of Health. And you can see where we are in 2022. In some cases, we have data from 2020 and 2021, so you can actually see the change in progress. But the biggest thing to note here, and that's really what's going to shape our recommendations, is that the technical aspects, doing an analysis, doing an assessment, doing standards, these are things that countries are really moving ahead on. We see a lot of green bars here, meaning that they have completed this step. So that's very exciting. It's great to see that that's moving forward. But when it gets to more of the resource intensive or integrative intensive steps, such as infrastructure, monitoring, health workforce development, we see much less progress. And this report really tells us that though countries are making strides on this, a lot more is needed if we're going to meet the 2030 goals. And so that's where we get to our recommendations. And that's what I want to focus on today. Although, Haley, maybe you can do me a favor and drop the report link in the chat in case people haven't had a chance to read into it. So there were 3 recommendations, and actually these are a bit of a similar to the recommendations that came out of the 2020 Fundamentals First report. They've just been streamlined a bit. So they went from 4 to 3. And so the first recommendation is that we integrate wash, waste, and energy services into health planning, programming, financing, and monitoring at all levels. You've probably heard us talk about this before: integrate, integrate, integrate. Certainly easier said than done, but something that is recognized as really the first step to ensure sustainability of these services, and in particular, financing of these services. So what does this mean for you? To me, this says we need to advocate, because at the end of the day, most of the practitioners in our community practice do not come directly from the Ministry of Health. And even if you do, you probably don't have unilateral decision-making power. So that means that we need to advocate. We need to regularly engage with health officials on your programming, making sure that this isn't something that's being done entirely separate from the Ministries of Health, Ministries of Water, but that there is engagement from conception to design, implementation, monitoring, etc., that they see and feel part of this process, they have input, but also that they can see the impact of this and working across, and the valuable role of WASH has in these healthcare facilities. You can raise awareness of remaining needs and the realities in the healthcare facilities where you work. This, again, could be at any level. This doesn't have to be with the national government. This could be subnational. This could be at a local level. Making sure that the health system is aware of the needs of WASH, as it might not be something they've prioritized in the past. You know, offer technical support. So though I did mention many countries are moving forward on those technical aspects of the 8 practical steps, you can see not everyone has completed them. So certainly there is valuable support that this community can provide to ensure that these assessments, these standards, this dissemination of information is reaching the people that need it most and have your strong technical input behind it. And then lastly, participating in health meetings and events to advocate for WASH in healthcare facilities. This is again where making sure that voice is heard, participating in a roundtable on the AMR national action plans, and making sure that WASH is integrated, ensuring that that is one of the key pillars to prevention. We hope that our health colleagues are speaking up about this, but in order to be sure of that, it's important that we engage. And again, this doesn't have to be nationally. You can do this at any point within the system where you work. Recommendation 2 is on monitoring. So regularly monitor and review progress and strengthen accountability. What does this mean for practitioners? Well, we also need to monitor. We need to monitor our own programs and regularly share data with our national and local health officials, as well as the facilities themselves. We need to practice what we preach, as it were, ensuring that this information is getting back to the people who need it most. This may even include integrating your data into a larger data set for the ministry. For example, if they have an assessment going away or starting to develop more routine monitoring. Consider not only basic WASH service levels, but additional metrics that might support recommendation number 1. So this could include costing and budgeting data, patient and staff satisfaction. This could help demonstrate the role that WASH plays in the healthcare facilities, that it's not as costly as it is typically assumed to be, the specific needs that are in place. I think this is really crucial to help reinforce this integration process. We can advocate for the government to integrate indicators into the HMIS system. That's really what this recommendation is ultimately getting at, and we can be advocates for that. And we can participate in discussions on the appropriate indicators for that country, providing any necessary technical advice. Lastly, recommendation 3 is develop the health workforce. So this is develop and empower the health workforce to deliver and maintain WASH, waste, and energy services and practice good hygiene. So what does this mean for practitioners? We need to engage in capacity building. This means that anytime you do a program, and I know that all of you already know this, but I will just say it for the sake of it, we can't just be focusing on the infrastructure or the service delivery. We need to ensure that there's a capacity building component to this work, particularly around operations and maintenance. That includes bringing in non-clinical staff, such as cleaners and maintenance workers, when it's appropriate. Advocate for not just service delivery, but also behavior change programming. And this might be advocating for in-service behavior change options, as well as pre-service. You can partner with Ministry of Health on IPC programming, ensuring IPC adherence as well. And then you can provide technical support to any effort to create more of a cadre of professionals, wash, waste, energy professionals. So today, we're actually going to go in a little bit deeper to this developed health workforce piece, which certainly has many components. It's not just about behavior change. Developing the health workforce means making sure that job descriptions exist, that there are trained individuals before they reach the healthcare facility. But we do want to dive into this more deeply with our colleague from CDC, Chrissy Craig, because I think we spend a lot of time in this community practice talking about the what. What do you train people on? You train them on environmental cleaning. We train them on hand hygiene. And we don't spend as much time talking about the how. How do you do behavior change and how do you sustain behavior change? So again, that's not the entirety of developing the health workforce, but one particular component that would be valuable for you if you include capacity building as part of your programming, which I hope you all will consider. So I think I will give you one more slide. The resolution and global action plan looking ahead. So you may be familiar that there will be a proposed UN resolution on wash, waste, and energy in healthcare facilities. This is taking the World Health Assembly, which essentially the reporting back system for that expired this past May, and we're opening up another accountability system here through the UN resolution to ensure countries are moving forward on the 8 practical steps and meeting the 2030 goals. So that will be discussed by the General Assembly in November 2023, and we're very hopeful that they will go ahead and pass that resolution. Then for us to actually go and achieve that resolution, WHO and UNICEF are putting forward a global action plan. And that action plan is really structured around these recommendations. So there'll be much more specifics on how we go forward and address these throughout the system. So now I will hand over to Haley to talk about some of the recap of what we've done in the community of practice that can really support these recommendations and support you to achieve all those steps that we put forth. Haley, over to you.
Great, thanks so much, Lindsay. Yeah, I'm going to just provide a brief recap of the Washington Healthcare Facility COP. There's so many events and resources that we've discussed over the past 2 years. It's so hard to kind of condense this down into just a few slides here. But I do want to share just maybe some metrics and highlights that we've achieved over the past 2 years together. So in total, the COP events that we host, we've had 13 of them. This is the 13th. We've had a total of 1,240 participants across the 13 events. And we've had over 2,800 viewings of our previously recorded events, which are just really great numbers to showcase just how many different topics we've covered, how many different people have been plugged into these things. As Joanne said, we do send out a newsletter every month. We've actually sent and created 17 of them with different resources and different areas, kind of highlighting different components of Washington Healthcare Facilities. We do have our listserv, so people that sign up to get information about the events, that get the newsletter. We have about 1,090 people, which is just a huge number, and it's been really exciting to see that number grow, after the different events that we have. We also do have a YouTube channel where we post different recordings and videos, and we have right now about 453 followers, which is just, again, just a great to see the engagement from the community of practice, that you are kind of tuning into these different things here and finding those recordings and different resources there. You can move to the next slide, Lindsay. So as I mentioned, there are 13 events that we've had. If this is, the first event that you've joined, or if you've been with us from the beginning, you can see that we have covered an array of different topics here, from asking an expert to talking about climate resiliency, gender, O&M, data for action. We've covered so many different topics here. And so this is kind of just a snapshot slide to show all of the different events that have taken place. You can go to the next slide, Lindsay. And if you're wondering, wow, these are so many great events, where can I access these? How am I able to see these recordings? You can go to Washington Healthcare Facility or washingtonhcf.org/COP. Lindsay did just put the link in the chat there. If you go to that website, this is what it will look like. There's a section that's called Previous Events. And there's actually a tab for each of the events along with the date that that event took place. If you kind of expand that tab there, you can actually find the access to the recordings in both English and French and Spanish. You can also find, the slides or the PowerPoints that were created for those events also there as well. So it's a really great site. It has a lot of information, upcoming events will also be posted there. So it's kind of a catch-all for all things related to the events that we've had through the COP. Can you go to the next slide, Lindsay? Oh. Along with that, we have developed videos or new videos, mostly taken from the events that we've had in the past. So we do have 2 new videos. The first is called Weathering the Storm. It's all about climate resilient Washington Healthcare Facilities programming. And then the second one is about clean care, focusing on environmental cleaning in healthcare facilities. Both of these are really great. I think roughly around 10-minute videos that kind of highlight these topics and kind of dive into hearing from specific speakers that were included in these events, and really just provide kind of an overview and highlight of those topics and areas. You can access those on our YouTube channel, which Lindsay also just put in the chat. So feel free to check out both of those videos. Again, like I said, they're very short, about 10 minutes long each. And they really just provide a really great insight to both of those topics there. Go to the next slide, Lindsay. So this is just a snapshot again of what that YouTube channel looks like. And there's many more videos that are posted there actually. So not just the shorts that we're sharing here, but also links to all of our events. So again, in those 3 languages, English, Spanish, and French, you can find all of the COP event recordings on our YouTube channel, along with other types of events or webinars that have taken place in relation to Washington Healthcare Facilities. So it's really a great place to kind of peruse and learn more about different events that are taking place both within and outside of the COP. Next slide. Great. And so as you recall, a couple events ago, we did actually meet and discuss Washington Healthcare Facility indicators. We've also talked a little bit about a literature review. So these are just 2 kind of newer resources that we wanted to update you on. So the first is that there has been an updated literature review on Washington Healthcare Facilities. It's a really great document that kind of provides all of that research and learnings on healthcare facilities. And then in addition, we do have a list of indicators from Washington Healthcare Facilities. This list actually came together from COP members. So if you remember, we did have an in-person event last year where we talked a lot about indicators. And so this is kind of the document that came out of that discussion. So it has had a lot of input from people on this call, from our COP steering committee members. And so we really encourage you to take a look at that document. And there's also, again, a lot of those resources that are mentioned on these documents are available in all of those languages, so English, Spanish, and French. And all of these will be available actually on our Washington Healthcare Facility.org/resources. So you can go to the next slide, Lindsay. So I know that we've just kind of covered a little bit of resources here. I do want to direct you to our Washington Healthcare or WashingtonHCF.org/resources page. We're obviously, I'm not going to take the time to go through every resource that we've talked about through the COP. That would just take way too long. But I do want to note that next week, so following this event, we will be sharing a newsletter that has really all of these resources that we've talked about in a compilation of resources that have been mentioned from all of the COP events and newsletters. So that'll be sent to everyone that's included on that listserv or has signed up for that listserv. So I encourage, if you haven't done so already, please sign up. If Lindsay if you could put the link in the chat there, that would be great. So that you can get that newsletter. It will include a lot of the resources that I just mentioned here, links to all of our recorded events, It will include the content from this event, as well as the different resources and documents that I mentioned here today. So, and again, I encourage you to do that. And now I'll turn it back over to Joanne for part 2.
Hi, thank you. Thank you so much, Lindsay and Haley, for those wonderful recaps and summaries. Again, a lot has happened and a lot is going on as we think about the global recommendations. Before we move to part 2, though, we want to do a pause for a minute and do a quick poll with those who are here with us. And so just 3 questions for you to consider. If you go ahead and launch. Think about your circumstance. Have you been working on any Washington Healthcare Facility projects over the past 2 years? That's the first question. Do you have plans to undertake any, if you have not, in the next 12 months? And then have you utilized any of the resources that Haley just went through over the past year or so to support your Washington Healthcare Facility activities? Again, this is just really good information for us to have and for you to see, as well as, your colleagues, in terms of who's doing what and how these resources are being used. So take about 30 seconds, if you will. And yes, I see lots of people completing the poll. We'll give you another few seconds and then we'll show the results. Yeah, almost everybody. So if we can just a couple more people, just go ahead and take a look at the poll before we close down. Give it another 10 seconds or so. All right, we can go ahead and close out. Thank you for all those who were able to complete it. So we have about 80% of you who responded who are actually working on Washington Healthcare Facility projects or have done so in the past 2 years. So really great to know that we have lots of folks who can share experiences and ask questions, especially when we get to the Q&A period with Christy Craig. Those in terms of plans to undertake projects in the next 12 months, again, another 80% say yes, that is part of your future in terms of what you'll be working on over the next year. Some are not quite sure, so this is great. We're glad to have you here. Perhaps something you hear today can kickstart some of your programming, especially as it relates to behavior change. And then have you utilized our resources? Really great to see 62% have been able to go onto our archive over in the website that Haley talked about, or our newsletters. Really wonderful. And hopefully the other 40% who have not yet done so can plug in based on all the information that we provided in the chat in terms of our YouTube page and where that website lives, etc. And again, the synopsis newsletter that's going to come out in another week or so can help maybe direct some resources to those of you who have not yet used some of our information. So I'm going to now shift over to part 2. Hopefully everybody can see my screen. Okay, so now we're here where we're going to talk about behavior change and then hear from our special guest, Christy Craig. As we prepare to have this conversation, our learning team thought it would be good to have first, before we hear from Christy, a general discussion on behavior change as it relates to Washington Healthcare Facilities for those who may not have started working on these issues, and then maybe giving all of us some things to consider as important points as we launch into this phase of our work in programming. So as you heard earlier from Lindsay, we situate this section on behavior change within the recent global recommendations for Washington Healthcare Facilities regarding the healthcare workforce and specifically addressing the issue of behavior change programming. So while we'll be focusing on training and talking about other knowledge transfer, skill building activities, we want to make sure that you also consider a broader approach to behavior change. And so we're going to talk about a useful tool, especially for non-behavioral specialists, that you can use to think about the multifaceted behavior change approach that is generally needed to see sustained behavior change. So I'll preface by saying that there are a number of behavior change models. You may already be working with one in your organization or in your agency. And so I will say that this is a very intentional selection on our part to choose to talk about the MICHIE, M-I-C-H-I-E, behavior change wheel. And we do so, or I do so, because of several features that we think that are important for Washington healthcare facilities. So this talk is going to come directly from an open access article by Susan Michie, Van Stralen, as well as Wes from Implementation Science in 2011. So I think Haley is going to drop that link in, or has already done so. And so Michie and colleagues developed this new classification system for behavior change interventions, or what we consider to be that collection of activities that we do in order to change behaviors. And what the system does is it takes into account first an understanding of the nature of the behavior that you want to change. So what exactly is your target behavior, which Michie does within the article in terms of laying it out through a CALM-B behavioral model. Again, that's the model that Michie has chosen to use, and it's capabilities, opportunity, and motivation. And those are the parts. Again, you'll see a little bit more detail as we go through this talk. But they've decided they have looked at behavior through the lens of this model, and really said that we must first know what about behavior, what characteristic of behavior do you want to change? And then selecting among a landscape of effective intervention options that Michie also organizes, asks what behavior change approach would match the characteristics of the behavior that you want to change, as well as take into consideration the context where the intervention will take place. And this matching is really done because of a very careful analysis that Michie and her colleagues have done around which types of interventions have been reported to match up with specific target behaviors and then have been shown to achieve effective outcomes. Again, it was lots of literature review, going through lots of different kinds of intervention approaches and seeing which ones are the most effective for specific types of behaviors. So to be clear, this system does not recommend specific techniques or activities. It doesn't tell you to put up posters or have special speakers come in or exactly what it is that you should do, but it talks about the general behavioral change approach that you should take. So, well, what are we talking about when we talk about approaches? So this is the wheel. So when we talk about behavior change wheel, and so each of the items that appear on the spokes, if you will, are approaches that you can use for behavior change. So education, persuasion, incentivization, coercion, training, which is what we tend to talk a lot about, enablement, modeling, environmental restructuring, and restrictions. And so again, take a look at this wheel. And really, if you look at the center, it begins, as we mentioned, with the behaviors, that CALM, capability, opportunity, motivation. That's the way that Michie conceptualizes behaviors. And then even within those three elements, there are two subtypes for each. So under opportunity, you see social and physical opportunity. Under motivation, you see automatic and reflective. Capability, psychological and physical. Again, if we had more time, I do this class within 3 hours. We would go through each and every one of these, but you can also take a look at the paper where all of this. And really, once you characterize which aspect of behavior that you want to address, ideally this wheel should turn. We're a bit limited with our two-dimensional structure here, but this wheel would turn, and what you would do in turning the behavior, you would find which intervention option matches the behavior that you are trying to change. And so because we are limited with not being able to turn this wheel, and what you see here is not necessarily the exact layout, what we've done, and this is courtesy of one of our faculty members here at Rollins, Dr. Matthew Freeman, who's associated with the Environmental Health Department. You might be familiar with Dr. Freeman, who's worked a lot on Washington schools. What you have is another rendition of this wheel. And really, it's the same items, but it's just expressed a bit differently. And what you see are the, again, behavioral characteristics are along the left-hand side. And then you see the intervention options across the top, right? And what you have are these colored boxes that indicate the match, right? So what we mean by this, if you were to look at, for instance, you want to identify the behavior of physical capability, you want to deal with that aspect. And for Mickey, what that means quickly is addressing people's ability to actually the physical skills, whether they have those skills needed to engage in the activity. For example, do healthcare workers have the proper hand washing skills? Do they have the ability to do the hand over hand, let the water run? Are there any disabilities or anything that limits that? So that physical capability, if you're trying to target that, then you see the match for something like this includes training and enablement, right? So enablement, if you remember from, you may not remember from the entire wheel there, means removing barriers, right? Another example would be if we are looking at changing physical opportunity. Again, in Mickey language, physical opportunities really has to do with the physical or environmental factors that lie outside of the individual that either promotes or sometimes hinders the behavior. For example, under the same hand washing scenario, you may have someone who can do the physical skill, that may not be the issue, but really what you're looking at is the context that they're doing this work in, that physical context. And so then the question becomes, is there hand soap? Or is there available alcohol hand rub within the space that they're in that will promote the behavior of hand washing? Again, I leave you to read more about how to identify the behaviors within the Mickey article, but you can certainly see how this wheel is a handy tool to help you understand the various options you have to work with. And it almost forces you to make sure you know when you undertake behavior change programming that you're very clear about what component of behavior you're trying to change. The important part for us to see here is, again, if you look at this table, that training or education, which is sort of what we like as public health people, global development professionals, is only one approach for behavior change. But that depending on the target behavior, it may be that training is either less effective, or it's been shown to be less effective, or there are other interventions that you might need to use to amplify or to support what the training might do. Really quickly, I want to show you that the Mickey behavior change wheel is actually a layered wheel. So it doesn't only match target behaviors to potential interventions that we just saw. So if you see the wheel is the green behaviors in the middle, the red is really about the interventions that we just talked about, but now you have this other layer, this gray circle, that third layer that really shows us policy actions. And again, through literature review and lots of analysis, Mickey was able to layer onto this which policy actions have been shown by research to support or amplify the effect of the interventions that you have chosen to use. Again, those interventions being based on the behavior that you've chosen to target. Again, it's a multi-layered wheel, very effective. Again, this is a high-level, simplistic explanation of this wheel. Again, I wish I could turn it for us, but this is sort of the limits that we have. But I also have another table with the matching the boxes as well, if you wanted to understand how the policy actions also play into your behavior change programming. But I encourage you, if you can, again, to look at the article. It's open access. Haley's already dropped the link. There's also a very easy to read book where Mickey and colleagues also fleshes out the terms that I've just gone through that is in this system that is used. And again, it can be very useful for those of us who are not behavioral change experts. We do not know all the different behavioral models that could be used to build programming, but it really just gives us a very handy way to go forward and, again, identify those behaviors, pick from among effective intervention options, and then consider what policy actions should also support this. Now, the principles of this model, this Mickey model that we've just talked about, really maps quite nicely onto the WHO multimodal improvement strategy model for hand washing. So this is the basic schematic of the model with the 5 critical components that WHO has advanced in terms of improving hand washing. But if we take a closer look and think about what we just talked about with Mickey, The target behavior being hand washing, which we could again break down even further based on that model that Mickey uses. But the idea is that there are several types of interventions besides the training that need to happen in order to see sustainable behavior change. So for us, I've highlighted some of the ones here in the model. The resource availability, so that kind of sounds like the enablement or the environmental restructuring that we just talked about from Mickey. Reminders, a specific example, but really falls in that motivation section of needing cues and helping people want to do the behavior. And then changing the culture, right? This sounds again a little bit like the external factors that Mickey talked about, that in this case includes social norms that could impact the behavior. Again, you see sort of how it all holds together very nicely, and the WHO model really being a good example of how there's just this need to have many different interventions going to change behavior. So we've talked about hand washing quite a bit. There are other behaviors that you might want to target. It might include what you have here. Again, some of you who've been with us in previous COP sessions may remember this Venn diagram that helps us understand the overlaps, especially between IPC and WASH. So while this diagram is not comprehensive, it might be a useful starting ground for identifying which behaviors do you want to target that is associated with improving infection prevention control in healthcare facilities and WASH. So really, this last piece was just about behaviors, right? So behavior change models, behavior change intervention approaches that can help you in terms of beginning your programming. Another set of considerations would be the target population. So who exactly are we training, and some of the dynamics that exist among healthcare workers. So this is a short list of the general profile of the different kinds of people within a healthcare facility and their respective roles. As you think about behavior change programming in healthcare facilities, it will be important to note direct responsibilities as well as unwritten or indirect responsibilities that these people have. So for example, you might have a head nurse who's generally responsible for smoothing out the transition between surgeries and patients, but at times they may actually step in to help clean the OR floors when the staff is either out, absent, or limited. So then you have someone who's in one role, but actually having a different set of functions, right? So this is all part of what you should think about in behavior change programming. Another feature is in the healthcare facility is hierarchy. It's important to understand and appreciate, as with every organization, there's a context where this intervention will occur. And so there is a general order of clinical or facility authority. There are power dynamics, and also what the presence and absence of certain authorities mean for your intervention. So when the physician or the manager or the hospital director is not present in the facility, who are the next level leaders, and how does that work in terms of hierarchy, power, authority? That's a really important piece in terms of putting together your behavior change programming. The issue of leadership is also important as we apply a gender equity lens and recognize that according to the WHO, 75% of the healthcare workforce is female, yet not more often than not, the top leadership positions are held by men. So we have to think about what that means for your behavior change programming in terms of just the interaction between women leaders or women non-leaders and the clinicians and everyone who's in that particular unit or the particular area of the hospital that you're working in, and what are the implications for training. The last consideration are the many types of behavior change interventions that already exist. So the different kinds of programming Lindsay talked about. We've seen all kinds of packages, examples of training programs that have been done for different types of purposes within Washington healthcare facilities. So here quickly as a summary slide, I'm not going to go through this whole thing, but you see from managers, we've often seen the clean clinic approach, just sort of a high level way of thinking about a number of different elements within the facility, or as including other regional partners that'll be required in order to move forward with this kind of training. We have clinicians who have just basic WASH for health kinds of training. We just talked about the MMIS for hand washing. We have Teach Clean. We talked about non-clinical staff and specific cleaners. And this Teach Clean package by the Soapbox Collaborative has been really important within the sector in terms of having an example of a really strong package to address training needs for cleaners, and then patients and caregivers, some of sort of the promotional activities that we have around hand washing day. So here's what we know. There are some behaviors that we can target for behavior change programming. So we just talked about hand washing, environmental cleaning, etc. There's some general populations that we can target when we take into consideration our behavior change interventions, and realizing that training is not the only method, that we should really be thinking multimodal strategies. And that there are important considerations within the healthcare facility that have to do with hierarchy and dynamics, and what kinds of health workers are doing what kinds of responsibilities and roles, right? But then how do we pull all this together? These are great features to really sort of know this is how you maybe start putting the recipe, but then how does that really work in reality, and what actually works in healthcare facilities? And so with that, I want to turn to our special guest, Christy Craig, who is actually here with us today in person. But if any of you have been following our US news, we were on the cusps of a government shutdown that would have excluded Christy from this session. So in order to capture her wisdom and get her insights, we moved forward last week with recording a session where Christy and I went through her presentation in sort of prior to this impending shutdown. So even though she is here with us, she's already waved in her box, the video came out so nicely. We're going to go ahead and show that video and then have Christy come in afterwards with additional comments and then help us facilitate the question and answer period. So go ahead and please write down your questions, think about some of the stuff that we've just talked about in terms of the basics of behavior change, and then we'll come back with Christy Craig live. Okay, passing it on to the video. Hi again, welcome, Christy. So glad to have you join us. We are really pleased to have this discussion with you because as a behavior change specialist, we are so very interested in understanding sort of what your thoughts are about seeing transformative, sustainable behavior change within a healthcare facility. So we're going to get started with a few questions for you. First, I'd like for you, if you could, just tell us a little bit about your background and your work in healthcare facilities, WASH, IPC, as it relates to behavior change.
Great. Thanks, Joanne. It's great to be here. So I work at the U.S. Centers for Disease Control and Prevention as a WASH behavioral scientist. And for the last few years, and especially throughout and after the COVID pandemic, I've been working a lot on behavior change in healthcare facilities. So among healthcare facility staff, working on hand hygiene, understanding barriers and motivators to practice, and developing and assessing interventions in that space.
Great, thank you so much. And I'm really glad that you said motivators and barriers, because that's really tied to one of our biggest questions for you. So thinking about your work in settings that are resource limited, specifically hospitals or healthcare facilities, what kinds of motivators and barriers have you found that impact WASH-related behavior change, such as hand hygiene among the staff?
Thanks for the question. Yeah, this is a key piece of this work, is really understanding what helps and hinders people when they're trying to practice hand hygiene behaviors and other WASH-related behaviors. What we've seen in some of the projects I've worked on, especially my work has been in East Africa and Central America primarily, but we've seen that one of the largest motivations is self-protection and protecting oneself and one's family from the risk of illness. And to a lesser extent, but still a motivator that we've seen is a desire to protect one's patients, which we would always hope to see. And I think really a very key piece of this motivation is just the perceived risk around the risk of illness for oneself or one's family or one's patients. And we see that perceived risk kind of go up and down. And I think also we talk a lot about motivations that are kind of more reflective and that we've thought about, but habit is also a motivation. It's an automatic motivation, but that's another thing that we've seen really drive behavior. As far as barriers, probably the biggest barriers that we have seen across the board are lack of time and just having competing priorities and working in settings where everything is urgent and there's a high workload and high patient volume, and it's just challenging to prioritize that among other competing priorities. And then also very closely tied to that is lack of resources and materials. And this is tied very closely to time, because if there are resources and materials for practicing hand washing with soap and water, or use of alcohol-based hand rub or hand sanitizer, if it's not readily available where staff are at all times, then the time component comes into play, because then it would take time to go and find those resources. And then finally, one more piece is just some knowledge gaps that we've seen that create a barrier just in terms of understanding alcohol-based hand rub and when and what constitutes patient contact and when hand hygiene needs to be practiced.
Great, thank you so much. And I can imagine those who are listening really are quite familiar with some of the thoughts you've just shared in terms of motivation dynamics, what people really, consider in terms of why they would or would not change their behavior. And then of course that, the complexities of the barriers that you've just been talking about. So if you had to look in your toolkit, I know you've been doing this for a while now, what kinds of strategies have you found are needed to initiate change? And then what are the strategies that will help sustain behavior change?
Yeah, I think you make an important distinction there. I think it's one thing to initiate behavior change, but it's a different challenge to try and sustain it over time. I think we can see when infrastructure is focused on as what's going to be improved, which addresses the issue of resources and ideally also helps with the barrier of time, that may initiate a behavior change. The novelty of access and new materials being available, but that doesn't always lead to lasting and sustaining change. So we've seen that in a number of studies and projects that we've done, that evaluations have shown that practices decline over time if infrastructure is the only thing that's changed. So to sustain it, I would say it needs to go beyond infrastructure and really focus on behavior change strategies, which of course is what I love to do. And so this can look like a number of different things. You can conduct surveys among staff, knowledge, attitudes, and practices, CAP surveys, to understand kind of where the knowledge gaps are, what attitudes staff have around certain hand hygiene practices. You can conduct interviews. These don't have to be, a big systematic study. It can be informal, talking with staff and trying to understand what motivates them, kind of looking at the why behind some of the challenges they've had. You can also conduct message testing, which is ensuring that the messages you're using or reminders or posters that you're putting up throughout the facility are understood and are context appropriate. And this also applies to different staff within the facility. So if you're working with physicians, nurses, and cleaning staff, the messages and the literacy level may vary even within your facility. And those are things to take into account as you think about how you can present messages to staff. And then I think really for sustainability, you have to engage at the community level, not just the individual level. And in this setting, when I say community, I'm referring to the broader culture of the workforce within a healthcare facility. Social norms really are a big driver of our behavior, and this applies to healthcare workers as well and healthcare facility staff. So I think recognizing that there are trusted leaders in a group and that those people may be followed. And if those people can model this behavior, that could lead to a shift in the culture within the facility and lead to a lasting change.
Thank you so much. That was so very helpful. Those are really practical and concrete examples of things that we can do to see sustained behavior change. Thank you again for that.
Mm-hmm.
So just thinking and staying on this point,
Mhm.
For those among us who work in multiple hospitals, what would you say about scale? We can imagine that everything you've described could work very well in one facility, but what about someone who's working across multiple facilities?
Yeah, I think scaling up is always the next challenge. Once you've figured out something in one facility, where do you go from there? So I think that's a great question. I think that there are ways that we can categorize facilities so that there doesn't have to be a completely new, novel approach in every facility. There will be barriers and motivators that are true across facilities as well. And of course, we want it to be as tailored as we can, but recognizing that we don't have unlimited resources to study this and study behaviors, we can look at facilities that are similar and the types of populations they serve. And if those are similar, then those facilities may benefit from having similar intervention approaches. Just for an example, I have worked on projects in Central America in small rural health facilities, and then in large public hospitals. And we did different assessments in those two types of settings, just because the needs and resources available, and even just the workflow were very different in small rural facilities versus hospitals. But we found that we could roll out similar work for behavior change across all 12 rural facilities and all 11 large healthcare facilities. And so I think thinking about kind of similarities and differences in the environment is helpful.
Thank you for that. I do like that, the concept of thinking about it in terms of groups and similar characteristics. So again, thank you for that. I think that should help many of us who are working in different settings. So another question for you, which I think a lot of folks ask, is if you don't have a behavior change specialist, such as yourself, on your team or accessible, what is your recommendation on how to either begin or initiate behavior change programs or initiatives?
It's a great question. And I think my answer would be no, you do not need to have a behavior change specialist on your team to get started on this type of work. I think health facilities are well equipped with people who care about health outcomes and promoting a healthy work environment within the healthcare facility can be done by those that work within it. And I think there's a lot of ways this can be done. You can develop a hand hygiene champions initiative. We've done this in a few different settings, and this can involve the selection of staff that are understood to be trusted leaders or role models for hand hygiene or other practices, and empowering them to promote behavior change among their peers. You can look at who else is already there and what systems are already in place. So if there's a hospital epidemiologist who could get involved, they're a huge asset for this type of work, or infection control nurses. If there's a weekly or daily huddle meeting, incorporating discussions about hand hygiene into those ongoing existing conversations. And I think just figuring out what systems are already there and integrating this work through staff that you already have doing this work is a feasible way to do this without a behavior change specialist on the team.
Great, thank you. And I know a lot of us are taking notes here.
Yeah.
So thank you for that. And so my last question for you is really based on the fact that, our platform is really about empowering everyone who listens and participates to take action. So if you could, and just really quickly, what can a person do, or a programmer or someone who is working in the facility do tomorrow to improve behavior change programming?
Thanks. Yeah, I think this can be change that starts now. And I think one of the first steps I would say, if you wanted to go and start this tomorrow, would be to really talk with staff in facilities and just set up opportunities to listen to their needs and their experiences. I think there's really a lot of value in understanding what is experienced by the people that are working in this facility to figure out how systems can be improved and how we can promote behavior change in that setting. And I would also direct you to the World Health Organization's multimodal hand hygiene improvement strategy, which if you just type it into Google, you'll be able to find it. Many of you are probably familiar with it. But I would say this strategy is a good starting point. It highlights different components needed to both initiate and sustain behavior change without getting too theoretical about it. And it integrates both infrastructure and education, reminders, and kind of the larger culture around hand hygiene in a facility, as well as evaluation and feedback, which I think are important pieces as well. So I think if you're looking for something to read through and look at for guidance, I would direct you there. But I would say really the first step is to talk with staff and understand what the gaps are, and then start thinking through what would make sense for adding some behavior change communications, or just launching a champions initiative, or whatever you choose to be the next step.
Excellent. Thank you so much, Krista. We really appreciate your time and all this great information you shared with us. I think everything you have said is quite actionable. And again, really appreciate you joining us.
Great. Thank you so much.
All right. So again, just giving everyone a minute to pause and think about everything that Christy Craig has shared. And again, we have Christy with us. So we're going to there she is, bring her on. And first, I just want to open up to Christy again. Thank you for spending time with us, first in this video recording and now returning. Now that you have the ability to be with us here live, so really appreciate your time. Know you're a really, really busy person. And so just wanted to open up to you if there are any thoughts or comments or anything that you want to share in addition to what you've already done in the video.
Joanne, it's great to be here. Glad I was able to be here in person today. And yeah, I would just also probably reiterate what you shared before about the COM-B model. I think that that's a model that I use in a lot of the work that I do. And I think you explained it so well, so clearly. So thanks for doing that, Joanne. And I think that's a really helpful toolkit. And the book you referenced is definitely an easy read, or a very clear read for someone who's not a behavior change specialist. I think it's very accessible. So if you're looking for more reading to do once you get through the WHO multimodal hand hygiene improvement strategy document, I would say that book is a really great resource. And I think, yeah, I'm just happy to take questions at this point, I think. Thanks.
Great, thank you so much. So again, if you have questions, please go ahead and start placing in the chat or raise your hand if you have audio capability, just so that we can see you and use this amazing time that we have with Christy to ask more questions. Again, you did such a great job on that video of covering so many of the questions and issues that we have heard over the past several years around behavior change program, especially about this issue of, well, we don't do this. We don't know how to do this. We don't have a behavior change specialist. So what does that mean? And again, you were so very clear in terms of those first initial steps that people can take. So I'm not seeing any questions right now in the chat. Let me give it, oh, I do see a hand raised. John Oldfield, please go ahead.
Yeah, Dr. McGriff, thank you. And Christy, great presentation. Just a quick question about the role of patients in this. It's difficult in any setting to be an empowered patient. You know, when I go to a doctor's office, you know, do I ask her or him, you know, when's the last time you washed your hands? You know, no, it's tricky. It puts us all in an awkward spot. I wonder if, you know, thinking back to the Mickey behavior change wheel there, to what extent is it possible to make it easier for patients to empower themselves? For example, could a poster be placed in an entryway saying, to patients, please ask your doctor or nurse when the last time is they washed their hands, or please tell me where the nearest hand washing station is. And so that sort of makes it easier for a patient to begin a conversation with a medical provider about WASH, about IPC. Otherwise, it's super hard even for me to initiate this conversation because I look like the bad guy, and then there's a trust issue perhaps. So just the question is the role of patients in behavior change within these clinical settings. Thank you.
I think that's a great question. That's something I've thought about and looked into in some of the projects that I've worked on. In one setting that we worked on, we actually proposed having pins that the staff wore that said, ask me when I washed my hands, ask me when I last washed my hands. And the staff did not like it. So I think, which is not that surprising, it really creates a very clear accountability system. And I think it's like that's still a bit of a hurdle to get there. I think it's a great idea. And I think it does empower the patient, because I do think there's sometimes a sense as a patient that there's a power dynamic and that you can't ask your provider to do something because they're the knowledgeable one, they're the trained provider. So patients don't feel empowered to do that. But I think placing some of that accountability on the patient to be able to do is a strong incentive for staff. But I think maybe it would take a little bit more conversations with facilities and staff, and just ensuring that within a cultural environment that would be seen as an appropriate type of dynamic and conversation, that's something we should definitely consider.
That's such a great example, Christy, about the buttons and just how that raises accountability. And it also speaks to a bit of what we saw in the MMIS model, is that in addition to something like, okay, wear a button, there needs to be almost like this culture that says it is okay to be held accountable, and that patients should be able to ask you. And so that's the additional work that has to be done. And like you said, these conversations that have to happen to warm people up so that they know we're not just putting buttons on, but that this is a thing that's going to be part of the safety culture here in the facility. So it's such a great example. Thank you so much for that. We have a couple of questions coming into the chat. Thank you, John Oldfield, for that question. Is there, and I believe this has to do with you mentioning champions and using that as a strategy. Someone asked, is there a specific outline for a hand hygiene champion program that you could share?
There are some guidelines I could share that were developed by my team for some of the projects that we did just with our implementing partners. These are based off of some existing similar projects and similar initiatives, but we tailored them to this specific kind of audience and group, and then we've adapted them for different settings that we're working in, whether large hospitals or small facilities in different countries. But yes, drop your email in the chat and I can share that with you.
Okay, great. Thank you so much. Again, a few more questions for you. So Samuel is asking that, connecting with what Lindsay shared in the beginning about the recommendations from the global report and the recommendations around systems level integration of WASH and health sector planning, as well as health sector monitoring, would Christy or others have recommendations on how to transfer experience of behavior change at the facility level to promote behavior or practice change at the systems level? So that's a really critical question here.
Yeah, I'll tackle that, but then I would love to hear from others as well what you think. I think this is really important. It kind of speaks to the scale question, but also the larger system, not just the scale of reaching multiple facilities, but the scale of having the broader system kind of incentivize some of these changes. I think it's critically important. I think it's challenging to make a blanket requirement across all facilities without spending time in the facilities actually addressing this on a smaller scale. to understand what works and what doesn't work. But I think once you get to that point of seeing positive effects of the behavior change work that you're doing, I think this is a really important conversation to be having at the broader systems level and integrating some of this into all of the facilities across the board so that it's an expectation. And then that also translates to the broader culture of hand hygiene and of safety. And if that can be kind of institutionalized at the system level, then that's what we would love to see.
Great, thank you so much. Lindsay.
Add a spotlight on myself. Thanks, Sam, for this question. I think for me, a couple of things that I would come back to are actually coming from the multi-module improvement strategy and thinking about taking that from a facility to scale. I think kind of to a point, Christy, you're saying there, but really thinking about champions and culture change. And I think that's the thing that's going to have the biggest impact here is doing this idea of building the champions, but doing that with systems leaders, right? Who within the Ministry of Health, the Ministry of Water is going to be a champion for Washington healthcare facilities to help ensure that it's prioritized. And so as we think about building champions at the facility level with a director, with key nurses, it's not necessarily always the Minister of Health. Well, often ministers of health have a lot of power, but there are other people within their system that can help drive change and drive influence. So we think about advocacy and we think about advocacy frameworks. We're always looking for that messenger and that champion to help move forward on this. So I think that's a big thing. I think also promoting this idea of culture change and a safety culture is going to be really critical in ensuring that this is something that's considered as a necessary component for the delivery of safe quality healthcare. And so often they're talking about that again from an IPC perspective, but I think we can adapt that for the WASH component and saying that this is a healthcare facility without WASH is not a healthcare facility. That's really saying that we're championing a culture of safety and a culture which that's no longer considered required. So I do think there are some translatable experiences from the facility up to the, within the system, maybe not at the highest levels, even you could even be doing this subnationally with district health offices and trying to build up from there and really have this sort of two-way street of advocacy, as it were, grassroots to grass tops, and ensuring that we're building that not just with nurses and doctors, but also with ministry leaders. Joanne, I don't know if you have other thoughts though, because your COMBI model talks about policy.
Yeah, it does. And yet it talks about it in terms of building off of individual change. So how do you get the individual to change from that inner circle and their behavior? And so what are systems level policy actions that can occur that will amplify that change? But if we're talking about in reverse in terms of how do you change the system itself, again, the elements that you talked about really is part of it. It's the issue of building that culture where the system sees the responsibility it has for safe IPC, safe WASH within healthcare facilities, and then all the other elements that Christy and Lindsay have covered. I want to, because we're running short on time, Christy, we have one more question, and I see there's a couple in the box. So thank you, Richard and Ruth and others who are putting in questions. But Ruth, you bring up a really interesting and often common issue that we find within healthcare facilities that Ruth says sometimes it's the management that is resistant to change. An IPC lead or a waste manager who feels that their authority is somehow being challenged or doesn't want to add to their workload. Do you have any suggestions for addressing some of this resistance that occurs when it comes to behavior change programming?
This is definitely a challenge. I think staffing for this type of work is challenging, which is part of why we've gotten creative in a lot of the work that I've done to try to introduce behavior change interventions that are not going to be a really heavy lift for the staff, because if they don't have someone dedicated to this, that just means it's going to take from an existing staff member's time. And so then doing things that won't be a huge burden on people. So either integrating it into existing meetings or having champions that wear these buttons that talk about their role as a hand hygiene champion. And I think conversations are just a big part of this. So understanding resistance, or why they feel like this is not something they want to see. If they feel like their authority is being challenged, maybe understanding how they would like to be involved if they want to be part of that and be in charge of it, then you can integrate them into that process as well. I think there's not one, right or wrong way to do it. I think it's conversations with the leadership and management and trying to integrate it in ways that won't be a big burden on staff. Those are some things I would say. I don't know, Lindsay or Joanne, if you have other thoughts, but.
Yeah, no, completely agreed. This issue of the competing demands, Christine, that you talked about, and the time constraints, resource constraints, people feel the pressure. And so really having good conversation and creating things that integrate nicely into their normal routine, really such a great way to help. It won't solve everything, but certainly it is a matter of kind of evolving the program as you have conversation. So great, thank you so much. So Christy, again, we just want to thank you so much for your expertise that you've shared with us. This is just so helpful. I can already see a short video or something that people can look at to really hear sort of just the common questions that happen, that occur when it comes to behavior change within healthcare facilities. And so I'm just going to transition quickly to the last part of our session. But again, thank you so much for joining us. And so here we are, we're coming to the end. Thank you so much for all of you who've been able to stay with us. But if you can just give us a few more minutes, I want to pass it over to Lindsay, who's going to talk about the new Washington Healthcare Facilities asynchronous course that we have been working on that might be of interest to you or your colleagues. So over to you, Lindsay.
Great, thanks, Joanne. So as many of you know, we at Emory have been working on Washington Healthcare Facilities for nearly a decade. If not longer, and have been focused a lot on knowledge and capacity building. And so we have developed a Fundamentals of Washington Healthcare Facilities course, which will be launched next year. It's an online self-paced course. It'll be 4 modules, and it's designed to equip particularly WASH practitioners, or certainly health practitioners as well, if they're interested, with a comprehensive introduction to the importance, severity, and implications of poor WASH conditions, and really help kickstart programming. So if you're someone who's super advanced, this might be a refresher course. If you're someone who is transitioning into the Washington Healthcare Facility space, this is a really critical course to help ensure you have all of the basic information. You're not recreating the wheel when you jump into programming. Registration will open in November, and the course is open for 2 months from mid-January to mid-March. It's self-paced, so you have anywhere within that 2 months to do the course. Again, it's 4 modules, and then you'll receive a certificate of completion from the Center for Global Safe WASH at Emory University when you finish. It's a $249 course, and we are hoping to offer it more than just next January, but have it open kind of repeatedly to make sure reaching as many people in the community who need to get these basics in place. I can drop the information about the course in the chat. But that is where we're transitioning to, because what you'll hear about in a second, Emory is actually passing on the baton from the community practice. We've run it for 2 years. Really grateful that you all have been so willing to participate and give us ideas on how to address some of these key topics in the area of Washington Healthcare Facilities. Joanne and Haley and I launched this initiative back in October of 2021, and I think it's time that we pass the baton on to someone else. So I think I'm going to hand over now to Ryan Cronk, Dr. Ryan Cronk of UNC Chapel Hill, to talk about their approach to the community practice, which will include all the things you love and more about the COP. So Ryan, I will hand to you.
Thanks, Lindsay. So I just want to, for those of you who don't know me, my name is Ryan Cronk. I'm an assistant professor in the Gillings School of Global Public Health at UNC Chapel Hill, and I serve as the research director for the Water Institute. And on behalf of the Water Institute team and our director, Dr. Aaron Salzberg, I really want to thank the Emory team, in particular Lindsay and Joanne for, and Haley as well at World Vision, for their excellent work in service and facilitating and growing such an amazing community over the past 2 years. And thanks also to the technical team and the steering committee and all the presenters who have joined this this community over the past couple of years. So we're really excited to take over the Secretariat for the COP and continue this great learning webinar series and curating the resources for the newsletter and website. And we also look forward to growing the community to serve your needs and the needs of the sector. So most of you are aware, but one of the agreed upon outputs from the Global Summit in Amman this past year is to strengthen technical capacity through a global community of practice and peer-to-peer learning network. And so we really look forward to working with WHO, UNICEF, you all and other colleagues to really launch new technical working groups that address global priorities, things like WASH fit evaluation and technical implementation, financing and budgeting, and other relevant topics. So we look forward to exploring opportunities to develop more in-depth technical training resources of interest to the community. So stay tuned for more information. We'd love to hear your feedback. I dropped my my email in the chat. And I'd also just like to plug, if you're coming, please let us know if you're coming to the Water and Health Conference later this month. We'd love to connect with you in person. There's at least one workshop and several great presentations and posters on Washington healthcare facilities. And if you can't join us in person, there is an opportunity to join virtually, and you can connect and learn from all the great content. So thanks again to the Emory team, and we look forward to working with all of you more closely over the next couple of years. Thanks all.
Joanne, hand it back to you.
All right, thank you. So we have come to the conclusion of our session, or the final session for year 2. You just heard from Dr. Ryan Crunk, who's going to be leading this community of practice into year 3. Again, we wish our colleagues over at the Water Institute at UNC, University of North Carolina at Chapel Hill, all of the best. And though you may not see Lindsay, myself, or Haley up front anymore, we certainly are very well vested in this community of practice, supporting UNC as needed. And then certainly you will have the guidance of the steering committee, who has graciously agreed to stay on and really continue promoting and moving this community of practice forward. So again, as Lindsay said, you'll see so much of this great material continue and expand under the leadership of UNC. So we're really very excited for these new changes. Again, if you have interest in the course, Lindsay has also dropped the sign up link that we've made available in the chat box. So if you don't necessarily think you need it, but maybe your colleagues who are working with you in your office or in your organizations or in your volunteer groups could use it, then please feel free to pass it on. We look forward to launching that program as well as many others as it relates to Washington Healthcare Facility programming. So with that, we're going to give you back 4 minutes of your life. You see that? I asked you to stay with us, and this is a treat that we're going to finish early today and just say goodbye. It's been so wonderful working with you all. And hopefully if anybody's ever in Atlanta or in DC, please stop by and say hello at Emory. We will be so glad to host you and have more conversations. Thank you so much and have a great rest of your morning, afternoon, or evening. Okay, bye-bye.
Thank you all. Take care.
Mhm.
Bye-bye.
Everyone.